now my pleasure to introduce our first keynote speaker, Dr. Fabio Cominelli. Dr. Cominelli has over 30 years of research expertise in the area of experimental inflammatory bowel disease and intestinal cytokines. His contributions to groundbreaking research on gastrointestinal conditions, including Crohn's disease and ulcerative colitis, have helped alleviate pain and complications for tens of millions of people worldwide living with these disorders. His group was the first to report that blocking a single cytokine producing a robust anti-inflammatory effect in animal models of colitis, and an imbalance between intestinal pro and anti-inflammatory cytokines represents a pathogenic mechanism of autoinflammatory diseases, including inflammatory bowel diseases. These and other studies have formed the foundation for critical clinical trials using anti-cytokine therapy, as well as administration of anti-inflammatory cytokines in patients with autoinflammatory diseases. In 2023, Dr. Cominelli was honored as a distinguished university professor, an honorific title that acknowledges the contributions of full-time tenured faculty with exceptional records of research, scholarship, teaching, and service by the Case Western Reserve University. Please welcome Dr. Fabio Cominelli.
Thank you. Thank you, Dan and Stephanie, the organizer of this, for giving me the opportunity to present some of our data. Before I start, I want to remember our beloved chairman, Bob Salata, who unfortunately passed recently. I still remember the days when I started here as a new division chief with Dan and Bob meeting and building the Department of Medicine that we have today. So today I want to talk to you a little bit about translational research going on in my group, in my lab, with specific reference to anti-cytokine therapy in IBD, and basically how this has really made a very difference in the treatment of this patient, and developed some new drug, FDA approved by the FDA for this condition. So this is my view of the pathogenesis of IBD. IBD includes Crohn's disease and ulcerative colitis, affects almost 3 million individuals in the United States, several million in Europe. And a cartoon like this that I put together many years ago tells you that we don't really know the cause of the disease. This is remembers me when in the 80s when we were talking about peptic ulcer disease, aggressive factor, acid production, and then Barry Marshall, who actually won the Nobel Prize for work in my division at UVA, discovered that a simple infection, Helicobacter pylori, caused a disease of such important like peptic ulcer disease. In IBD, there is a genetic susceptibility. There are over 300 genes that have been associated with IBD now, but in general, it's a polygenic disease, probably one of the most successful examples of genetic studies in complex diseases, with several genes identified, such as NOT2, which was the first one, TL1A, IL-23 receptor. And the importance of genetic study has been the understanding of pathways that can be targeted for therapy. In fact, today we have, Stelara is basically blocking this pathway, and very soon anti-TL1A therapy you will see in my talk. The environment is very important in this disease. There are many factors that have been associated with the environment. Of course, the gut microbiome, diet, smoking is the most important risk factor for IBD. Good in ulcerative colitis, bad in Crohn's disease. We don't still understand why. There is overall an epithelial cell dysfunction. The mucosa at the surface of our body clearly plays a major role in this disease. Now, the interaction of this factor leads to activation of the immune system, and one of the areas where the activation of inflammatory cells and activation of what we call cytokine gene expression. One of my contributions, as Stephanie said, was in 1990 to publish one of the first papers where blockade of a single cytokine was effective in treating this condition. And this was an important concept because in those days, the dogma was that you block IL-1, TNF takes over, you block TNF, IL-6 take over, you block IL-6, IL-23 takes over. So the idea that blocking one single cytokine like the TNF story has taught us, and you can have such a major impact on the disease, was a novel concept. So in my career, over 30 years ago, we started to concentrate on cytokines that we call, innate cytokines. So cytokines that not only are involved with the differentiation of some subtype of lymphocyte, but cytokines that have much more, a more pleiotropic effect, what we call a master cytokine effect, really to modify the inflammatory response in this situation. And this is a very interesting reflection about my career, the timeline of cytokine biology in IBD. When you get older like me, you start to develop timelines, you look back. And if you think about the interleukin-1 was cloned in 1984, I was fortunate enough to work with Charles Dinarello, who cloned and discovered the first interleukin-1. And from a series of studies, looking at IL-1, TNF, interleukin-33, now we have several drugs that are approved by the FDA for the treatment of inflammatory bowel disease. And I consider myself very fortunate being at the bench cloning the cytokines and then many years later to see drugs that are approved for the treatment of this condition. It doesn't happen every day, as you know. In terms of our approach, we have been using models, animal model, mouse model in particular, that are relevant to the pathogenesis of this condition. And there are many models. There are hundreds of models to study inflammatory bowel disease. The most common is the DSS colitis model, where you feed mice for a week with the chemical substance, and the mice develop some acute colitis. But these models really don't have anything to do with the human condition. So we try to develop models that are much more relevant in terms of pathogenesis and also, sorry, what did I do? Pathogenesis. I guess I touched something here. Okay. Models are much more relevant in terms of also the ability to predict response. One is called the SAMP mouse model. The other one is a model called the TNF delta mouse model. And I don't have a lot of time to explain you all the details, but these are chronic models. One spontaneous, where with multiple genes involved. The second one driven by an overexpression of TNF. We developed this model many years ago. So the SAMP, why the SAMP is so interesting, so important, because the mice have a pathology, localization of disease, the terminal ileum. As you know, Crohn's disease is also called terminal ileitis. They have these lesion skip areas, areas affected, alternating with areas that are unaffected, compared to a normal mouse, our control, you see where there is no disease, all the villi are intact. Obviously, this area cobalt lesion that we see when we open a specimen of a patient with Crohn's disease after surgery are where the action is going on in terms of inflammation, thickening of the muscularis, fibrosis, stricture, which are all event-generating symptoms in patients. The TNF delta is simpler in one way, the TNF delta mouse model, because it's driven by overexpression of TNF by a genetic mutation in the ARE region of the TNF mouse. We published this and developed with our collaborator George Colliers many years ago. It's a very popular model. Hundreds of labs are using this. And actually, with our center, we are able to provide these mice to investigators in the United States and all over the world. And the disease is a little bit different. It's continuous inflammation, but these mice develop two major pathologies, Crohn's-like ileitis and arthritis. As you know, the two diseases where anti-TNF has a major effect in patients. So the SAMP mouse spontaneous is also very important because mice develop stricture and fibrosis. This one is the hottest area in IBD research because obviously these complications of fibrosis and stricture are only treatable by surgery. There is no today medical therapy that will work in this situation. And also a discovery that was amazing to us that these mice spontaneously develop what we call perianal disease, so inflammation in the perianal area with fistula that penetrate into the rectum, inflamed rectum. These are one of the major complications in patients with IBD. Probably 30% of patients with Crohn's develop this complication. And to think that a spontaneous model developed this similarity with the human condition and the ability to study this condition for which there is very limited therapy is amazing. So the first cytokine that I want to talk to you about is the TL1A-DR3 system. We started to work on this probably 20 years ago. And the reason we focus on this pathway is that TL1A-DR3 as a co-stimulatory molecule for lymphocytes regulates or is involved in the regulation of all the major lymphocytes and cell subsets that are involved in inflammation in general, and in mucosal inflammation in particular, Th1, Th2, Th17, the new subset Th9, for which we have a paper almost accepted in gastroenterology now, innate lymphoid cells, which are the new kids on the block in terms of important cells in the mucosal immune system. So looking at a master cytokine that can regulate mucosal inflammation, IBD, this was a very good candidate. These other cartoons show you the different diseases where TL1A has been implicated, so not only IBD, but asthma, rheumatoid arthritis, other diseases, and all the different cell types that are involved. So again, another timeline, sorry, but this is a timeline that shows you what it takes to develop a drug after a discovery. So we publish, we discover, so this was discovered in DR3 by Human Genomic Sciences, TL1A, DR3 was, the receptor was described before. We published the first paper discovering the role of TL1A, DR3 in inflammatory bowel disease, and then, today we have clinical trial, phase 2 clinical trial. 20 years later, we have a drug that is approaching the FDA approval, and talking to the company now developing this, the first drug will be available in 2028. So it takes basically 25 years from time of the discovery to the development. Now, unfortunately, I'm not going to be a billionaire because I did not put my effort. So there are some investigators that pursue this field, and now the company that developed one antibody, Prometheus, has been sold to Merck for $12 billion. So some people are going to be billionaires. I'm not going to be a billionaire, but I'm happy because my approach to science, as you see, I don't have disclosure because I believe that academicians should not be involved with drug development. The two careers, in my opinion, don't go together. And I care about improving the quality of life of patients with IBD, and I leave to others to be billionaires by drug development. So I'm happy with my life and my discovery, and not being a billionaire. Anyway, besides this little transgression, the role of TL1A in IBD, so they just show you a list of studies that show all, I don't want to go into details, but TL1A is increased in lesions for patients with IBD, the receptor expressed in lymphocytes, so all the background in humans that provide the rationale for going after this. And I just want to show you these slides from our initial discovery, because I think this was a major discovery because at that time TL1A was considered an endothelial factor involved with vascular biology. We discovered that it was expressed in lesion of patients with IBD, that the receptor was expressed on lymphocyte. We discovered also the many cell types were able to produce this protein, and therefore providing a strong rationale for additional study. We went back to our animal models, and we show also the expression in, this is a paper published in PNAS, we show the expression of the ligand in our models and the appropriate expression of the receptor. So the approach that we use, and I can go fast here, was to develop genetic deletion of the ligand, the receptor in our mice, and to study blockade by antibody blockade to study eventually what will happen in patients. So these are our experimental procedures that we do routinely. So we cross our mice with the knockout models, then we generated the genetically mutated mice, and then we study all our fancy assays in terms of evaluation of colitis, endoscopy, cytokine measure, and so on. And this obviously is a large amount of data. I just want to show you this one, that when we cross our SEM mice DR3, when we cross our SEM mice with the deletion of the signaling pathway of the receptor, we saw a tremendous amelioration of disease, almost complete suppression of disease, compared to the normal mice, intact mice that develop this progressive chronic ileitis up to 40, 60 weeks. You can see here the difference histologically and the difference macroscopically. So this was very good indication that this signaling pathway is very important in this model. Several cytokines were suppressed, interferon gamma, TNF, IL-13, IL-17A, all cytokines that play a major role in mucosal inflammation. And one aspect that is very important of this molecule, this is probably the hottest area in gastroenterology. Every meeting there are tons of talk. Everybody talks about this. All the investor wants to invest on TL1A. I got one call a week from investors. They want to know about it. This is a good investment to invest in this market. There are probably 5 or 6 pharmaceutical companies now developing antibody for this. But one important aspect is the role in fibrosis, because there's been some important indication that this pathway is important in activating myofibroblast, fibroblasts, and therefore developing those stricture stenosis that I told you is one of major complications. And in our mice, when we look at our SAMP-DR3 mice cross with DR3, we saw a tremendous amelioration. So this is a normal mouse, this is a regular mouse, this is the knockout. You can see the difference in tremendous amelioration, not only inflammation, but the collagen deposition, and so on. So suggesting that this pathway could be very important in regulating fibrosis. Now, the question always remains, when you block a cytokine like this, is the effect of fibrosis because you suppress inflammation or you suppress inflammatory fibrosis genes? But we also did some analysis on the effect on fibrosis genes, and you see that, for example, alpha SMA, collagen 1, MMP3, there is tremendous downregulation of this inflammatory. So there is the hope that this could be a treatment once approved that increase or decrease the incidence of fibrosis in this. Then, in order to prove that this was not something specific to our SAMP mice, we turned to the other model. And in the other model, I just wanted to concentrate on this. We saw a very similar effect where the deletion of DR3 generate also a significant amelioration of disease. And also shown here in terms of histology, MPO activity, which is biochemical index of inflammation, and suppression of the pro-inflammatory cytokines that I described before. One very interesting thing that we observe is that when we cross our TNF with the ligand now, TL1A, we saw a much lesser effect in older mice. We saw really no effect of deleting. So deleting the receptor, very strong. Deleting the ligand, not so strong effect, but only early in disease, but not later. And when we do the same experiment with our SAMP mice, actually we saw no effect. So very intriguing results where now the drugs that are being developed are against TL1A, and it's not surprising that there is some effect there. So the effect is positive, but it's not certainly 100% resolution. So obviously our model represents probably a subgroup of the 70% patients that don't respond, they have lesser effect with TL1A. And we then did the neutralization experiment with antibody, and we saw a very remarkable similarities or identical results with the gene knockout, where blocking TL1A in the TNF early on was effective, non-effective in later disease, and non-effective in SAMP. So one area that I hope to pursue in the next 5 years in my new grant, if it's funded, will be to understand why blocking the receptor is more effective than blocking the ligand. More recently, we have a paper now almost accepted, as I mentioned, in gastroenterology. We turn to a new subset, which is Th9 cells and interleukin-9, which is another candidate cytokine for potential treatment of IBD. And when we use our SAMP-DR3 mice, we saw a significant suppression of interleukin-9, suggesting that this is another important pathway that is regulated by DR3, TL1A DR3, also showing here that basically there is, in our mice, lacking the receptor, there is downregulation of this pathway. And when we block interleukin-9 in our mice, also we have positive effect. So to conclude this part of my talk, is our results suggest a differential role of TL1A and DR3 in early and late stages of disease. DR3 has a pro-inflammatory role both in early and late phase of Crohn's disease like ileitis. TL1A displays different roles at early and later phase of disease. Obviously, the one explanation of our hypothesis is that there are more ligands than TL1A to activate the DR3 signal, which has been described for other cytokines such as OX40, for example, or LIGHT, other members of the TNF family have more than one receptor. So the conclusion is that the DR3 signal is a major regulator. A blocking DR3 may represent a novel therapeutic modality. Now, as I mentioned, there are companies developing anti-TL1A antibody. The prediction is that these drugs are going to be approved soon. We are going to be working on DR3 specifically to prove that blocking DR3 is more efficacious. So these are the future perspective of our work. So we are working on 2 known ligands for DR3 in addition to TL1A. One is called progranulin and one is E-selectin. We have already some good data that these are overexpressed also in our mouse model. So the idea will be that if you block TL1A, but also these other ligands, you are able to block completely DR3. And also, we are after very difficult task, the discovery of new ligands that have not been identified before that could explain these results. These are very talented people that work with us to develop this project for this part. And these are the 2 studies published today. Again, remember, the satisfaction of physician scientists to do it, make a discovery in 2003, and then see drugs that are effective in patients. It doesn't happen very often, I can guarantee you. So the first study was published in patients with ulcerative colitis with what we call the Pfizer antibody that now has been sold to another company. And the second one just came out a couple of weeks ago in the New England Journal of Medicine in terms of the Prometheus antibody in ulcerative colitis. But also there are studies showing that this approach is also effective in Crohn's patients. Now, a few last minutes, I want to tell you about another story, which is the story of IL-1. IL-1 has been obviously the passion of my life since I started to work with this in 1985. And interestingly, for interleukin-1, there has not been any clinical trials blocking IL-1 in patients with IBD. As you know, there is a drug, anakinra, who is approved for the treatment of rheumatoid arthritis and other conditions. But for sometimes difficult reason to explain, no company has gone after interleukin-1 in a systematic way for inflammatory bowel disease. And one of the reasons is what happened in the pharmaceutical industry. Nobody wanted to compete with anti-TNF, and it was difficult to push this issue. I believe that IL-1 has a very important role in IBD, and our approach has been to go after interleukin-1 alpha, because there are 2 isoforms of interleukin-1, one alpha and beta. Alpha beta is the secreted form. IL-1 alpha is function as an alarming, and basically is secreted, is released by epithelial cells and other cells upon necrosis, injury, with the function of what has been defined as an alarming. And our hypothesis is that this function in the intestinal epithelium could be very important in terms of pro-inflammatory effect. So there's been a lot of study related to interleukin-1. This is an advice for younger people. Please, I tell all my people in the lab, read the literature, because if you're young, you go to a study section and review a grant, you make statements. So my last grant, one of the criticisms was that IL-1 alpha and IL-1 beta, we didn't show that IL-1 alpha was increased in patients with IBD. So we published this, other people in 1990. Maybe the reviewers were not born yet, and therefore they don't know the literature. But please make sure that you know the history of some of the molecules. But anyway, a lot of work has shown that IL-1 is very important. And again, as I mentioned before, the alarming function is intriguing for us in terms of being able to release by cells through necrosis, pyropoptosis, other expressed, that could then create a pro-inflammatory effect to this molecule. So what we did, we designed, as usual, we obtained a very good mouse monoclonal antibody against interleukin-1 alpha, and we decide to basically do a neutralization study like we do for many of our molecules that we test. We use dexamethasone as a control. Dexamethasone works very well. So there are 2 things that work very well in some mice, making this model predictive of therapy: dexamethasone, corticosteroid treatment, and anti-TNF. Those are the gold standard of treatment in patients with Crohn's disease. We designed our study, and basically we assess the severity of ileitis with our usual system. We measure cytokines, and also we measure effect on the microbiome, and so on. So first, we prove again the IL-1 alpha and beta are increased in our sample mice. So on the top, you see our sample mice called Bestol lesion, control mouse. You can see the tremendous upregulation of both IL-1 alpha and IL-1 beta at the protein level and the transcript level in terms of upregulation of the protein, which is one of the things that you always want to see when you try to block a cytokine. And when we do our study, we saw a pretty remarkable effect in terms of anti-IL-1 alpha treatment comparable to dexamethasone in terms of statistical difference between these two groups. And you can see the histology: inflamed control mouse, one treated with dexamethasone and one treated with anti-1 alpha, the restoration of the normal mucosa with the villi, intestinal villi, the decrease in thickening of the muscularis that cause the stricture, and so on. So very good effect. Suppression of cytokines with increase of IL-18 that now is considered an anti-inflammatory cytokine. So very interesting that blocking IL-1 increase one of the family member interleukin-18. And to conclude this part of the study, in our model, we're able to show that IL-1 alpha may be a major pro-inflammatory cytokine. This may represent a novel therapeutic modality. At this point, we have been lucky to complete the planning phase of a clinical trial using a human natural antibody against IL-1 alpha, collaboration with this company, X Biotech. We actually, it's a very interesting story that before COVID, we obtained funding for this study through the DoD, so we got a fundable score. And then what happened, the company sold the antibody to a big, large pharmaceutical company. And what the large pharmaceutical company, without mentioning name, did, put this away, and there's not being way to test this. But because the original company still reserved the rights to develop new antibody, we have now new antibody that we can study in this area. So I think I'm doing okay with time. And so now I want to just try to conclude with one of the area also that is very important to me for the next 5 years of my career, maybe the last 5 years of my career, and the concept of anti-cytokine, advanced combination therapy compared to anti-cytokine monotherapy. So it's very interesting. If you look at the drugs used in patients with IBD, all the drugs work only in 50% of patients. We've never been able to understand why, but no drugs show an effect that is more, in the best scenario, of 50%. When we look back all the study we had done in our mice, when we use anti-1 alpha, we saw a 31% effect. When we look anti-SC2, which is a blocker of interleukin-33, another cytokine that Teresa Pizarro in our group here at Case is studying very extensively, and anti-TNF, 39%. So if you look at the primary response of patients with Crohn's disease with biological therapy, the response is 30%. Because, patients respond 50%, and then after 1 year, another 50% lose response. So this is unbelievable, remarkable in terms of how this mouse model resemble the primary response in patients. So one of the things that, again, if we get additional funding in the future, we're able to do, will be to explore the concept of advanced combination therapy, which is combined, obviously, molecule that has been done effectively in rheumatology, for example, and try to explore different combinations of cytokines. Of course, some clinicians that we work with are very excited about this, because by doing this advanced combination therapy in mouse model, in a relevant mouse model, you're going to be able to then develop good clinical trials in that area for patients. The idea is that by doing advanced combination therapy, you can break the therapeutic ceiling of 50%, maybe go to 70, 80% to really have a remarkable effect. These are the acknowledgement for the other part of the work, especially some of my collaborators on the right side, a series of very talented people on the right side. And most people are gone now, and we have very new postdoc and junior faculty are very talented. Okay, so I think I can finish at this time. I think I finished on time. And thank you very much. Happy to take any questions.
Thank you very much. Maybe I'll get the question started with one of the last things you mentioned, which was advanced combination therapy. And I wondered if you could just elaborate a little bit on what you have in mind.
Yeah. So the advanced combination therapy, to break the therapeutic ceiling, there are basically two approaches. One is to use drug in a different category. So you can use a biological therapy with a probiotic. You can use a biological therapy with a dietary intervention. So that's one approach. Obviously, the idea there is to hit the disease from two different pathways that have a synergistic effect. The other one is to combination therapy within the same class, for example, biologic, where you can use anti-TNF and Stellara, for example, and anti-23, and see, again, if by using drugs in the same category, you have a synergistic effect. Obviously, that's the approach that we want to use because that still gives you the option of use another category and not exhaust all the medical therapy at once.
Questions from the audience? Okay, I get to ask my second question then. Fantastic. You talked quite a bit about IL-1 alpha, and I just wondered if you could tell us, is there any more we should know about IL-1 beta?
Yeah. IL-1 beta is the classical IL-1 members. There are drugs that have been developed. Canakinumab is an antibody against IL-1 beta. There's been a famous big trial done with that. Anakinra is IL-1 receptor antagonist. But the concern about blocking IL-1 beta is that IL-1 beta has very significant homeostatic effect, regulation of epithelial cell integrity in the gut, barrier function. Therefore, the idea is that blocking IL-1 beta will be compensated by the deleterious effect of blocking the homeostatic effect. Therefore, we concentrate on IL-1 alpha for that reason. And actually, when we block IL-1 beta in our mouse, we see a much lesser effect on the inflammation, suggesting again the IL-1 beta, similar, for example, to IL-17. IL-17 in IBD, when it's been blocked in IBD, there are deleterious effects because of the homeostatic regulatory effect.
Simon.
So Fabio, you've been focusing on terminal ileitis or Crohn's disease. What is the biology differences between that and ulcerative colitis?
Yeah, so basically the ulcerative colitis affect only the colon, is continuous inflammation and superficial inflammation. Crohn's disease affects any part of the gastrointestinal tract. Interestingly, all drugs that we use work in both disease or they don't work in both disease. So that has been an area where we've been trying to understand the difference between the disease, but unfortunately, like in many other conditions, there are fundamental questions we don't know. Why Crohn's affect the terminal ileum and ulcerative colitis only the colon? But in terms of anti-inflammatory therapy, the biology is very similar and the drug works in both conditions. I hope one day we will understand more and being able to have specific treatment for one or the other disease. Yes.
Hi, Fabio. Great talk.
Thank you.
Quick question. So we know these anti-inflammatory effects are very effective, in the ileum and the colon. Can you tell us about some of the systemic effects, and then what do you think about the combination therapies that are being proposed? Will they only augment those sort of deleterious effects?
Yeah. So when we look at this anti-cytokine therapy, there is always the other side of the story. So these cytokines also have homeostatic effect. We produce cytokines in a normal situation if you don't have a chronic disease. So we always have to consider the possible side effects, right? So biological therapy, lymphoma, cancer, infection. So obviously, you gotta be careful when you push the combination therapy, where you push the side effects. So for example, blocking the IL-3 might have very significant immunosuppression that it won't make it a reliable source. So the question is excellent, and we always have to keep in mind, for example, now there's a company working with anti-IL-3, they're doing all the phase 1 trials, primate study, because toxicity is always a major concern. I guess similar to what you see in your oncology patients, right? So that's why I asked. Yeah, no, it's a very good question. I am very cautious when, to push immunosuppression. No, immunosuppression and autoimmunity are the price we pay for blocking, for biological therapy.
Great. Thank you.
Oh, thank you very much.
Okay.